So people are beginning to join the call. Welcome, everyone.
Hello, everyone, and welcome to today's session. We'll be starting in 2 minutes.
Sanini, could you put the poll out so that people can begin to fill the poll out while we wait for everyone else to join? So everyone, we have a poll. We're just curious as to who's in our audience today. If you could fill this out, that would be great. And actually, we probably should have had a other part just in case someone who doesn't see themselves on this list. Sanini, is there a possibility to add a other to the poll?
I will end this poll and start one again, okay?
Okay, all right. So we're trying to put out a poll just to get a sense of who's in our audience. Sorry for the other one, we missed the other. So we're gonna put the poll out again. If you could quickly just tell us your occupation and so that we get a sense of who is with us today. We had 67 people register. However, we know how that is where people register and then they realize that they sometimes can't make it. But we are excited to have you guys here. Sanini, can you put out the poll again?
Just 1 second, please.
While she's doing that, I just want to officially welcome everyone. Sanini Yura is our host today, so she'll be moderating the session. I just wanted to remind everyone that with this, our seminar, this is our 4th installment of the seminar, and we're really excited about what's happening so far. We're interested in speakers and topics. Remember, the seminar is about global perspective on medicine rehabilitation and robotics and / technology. So if you do have someone in mind that you think might be a good fit for the seminar, please send an email to myself. And that my email is usually located on the registration link for the site. Or if you have a topic that you wanted us to consider, please also send that.
The system is forbidding me to change the poll right now. I will start the webinar and we'll put the poll later on if you don't mind, Professor. Okay, sorry for this technical issue, guys. I cannot change the pool right now, but I will work on it. So first, I want to say hello to everyone and then welcome to today's sessions of Global Perspective on Medicine Rehabilitation and Robotic webinar series. This webinar series discusses how robot-assisted therapy can help bridge healthcare disparity gaps and allow clinicians in low and middle income countries to give better care to their patients by highlighting potential solutions to enable these technologies to be available. For this webinar, I'd like to introduce you to today's presenters, Tonya Arscott-Mills, the lead pediatrician in Botswana for the Global Health Center at Children's Hospital of Philadelphia. She will speak about rehabilitation needs for children in Southern Africa. And Michael Sobrepera will speak about social robots to improve tele-rehabilitation for children with disabilities. But first, as always, I would like to introduce you to our main guest of the evening, Professor Michelle Jolson. She's an associate professor of the Department of Physical Medicine and Rehabilitation and Bioengineer at the University of Pennsylvania, Philadelphia. Professor Johnson, the floor is yours.
Don't want to take too much time. I thank you guys again for coming. Really looking forward to having a wonderful speaker series today. I just wanted to put it out there that, again, if you have interesting topics or ideas for speakers, please touch base with me directly and we can try to see if we could work it out. That's all I wanted to say, and look forward to hearing you on the other side of the talk.
Professor Tonya, you can start sharing your screen.
Oops, slideshow. Oops. All right. Well, thank you to everyone who's here coming to listen to this talk and for having me to this webinar. As Sanini said, I'm a pediatrician. I'm based in Botswana with the Botswana UPenn Partnership and have been working there since 2008. I mean, the perspective I bring is really as a general pediatrician who's not necessarily focused on rehabilitation, but certainly in my years of experience there, I've seen the needs. And so in the next few minutes, I'm going to kind of just take you through some of the epidemiology of what we know about disability needs in LMIC lower middle income settings, and then particularly focus on Southern or Sub-Saharan Africa. And then from epidemiology, what we kind of know about what rehabilitation perspectives are, and focus in a very broad sense. And then finally, just focus on, for LMIC settings, what does the evidence suggest we need to think about as we think about rehabilitation services, again, from a very broad perspective. Because I think it's really then will give us a place to be able to have a discussion around how do we use robotics and other things to meet the growing needs. Okay. All right, so first of all, I just want to just quickly just remind ourselves what I mean. And when I think about both this disability, because this is where or how it's measured a lot in the epidemiological literature. And these definitions are both from WHO, where they say, you know, disability is a long-term physical, mental, intellectual, or sensory impairment which in interaction with barriers may hinder a person's full and effective participation in society on an equal basis with others. So you can see it covers a huge range of problems that a person may have. And so therefore the targeted therapies, et cetera, can also be very broad, but also has a very much a component of the environment or where the person is placed on how that impacts them. And so I think we have to think about that too in terms as we think about local solutions, because there may be things that are bigger, cause bigger disability in certain settings than in others. And rehabilitation is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. And this will be important as we kind of come towards it later in my talk a little bit about what interventions have been shown to work, because there's actually quite a bit that can be done with low resources when we think about this, given the number of variability of problems that we see. So moving quickly on to scope of the problem globally, it's very interesting. It's actually hard data to find, although there are a lot of modeling that's been done around this. And so actually all three of these references here are actually based on really modeling. But there's data from old data now from 2005, the UNICEF report on childhood disability, which showed about 150 million children they estimated had some form of disability globally. Interestingly, this and actually the one World Report on Disability in 2011 both use a 10-question questionnaire, which some in the literature suggest may actually overestimate disability, but it's really hard to know. But the World Report on Disability from 2011 noted that 93 million children they thought had moderate or severe disability, which is about 5% of the world's population of children. And I think it's important to note that they noted that about 80% of that in low and middle income countries. Now, the graphic that I have at the top is from the Global Burden of Diseases study. And this is looking at changes in disability adjusted life years between 1990 and 2019. And there's been huge progress in decreasing this for children. But I think it's important to note that if you look in the top 10, at least 5 of them, we know if a child survives this issue, can lead to severe disability. So neonatal issues, so although neonatal problems are becoming a much larger piece of the childhood under 5, morbidity and mortality, we know that kids that survive neonatal period with an issue, having had an issue in that period, are more likely to go on to have issues later. Congenital birth defects, malaria, meningitis, protein energy malnutrition, all of those have known long-term potential consequences for children that would potentially lead them to have disabilities or need rehabilitation services. And so this is kind of on a broad spectrum, just looking at it from the disability itself. But when we think about it, I think we also need to think about the context of LMIC settings. And I think this model is very good at thinking about the child is not hurt. The medical problem of the child is not in isolation. We know that children live in a context, and we know that kids in LMIC settings are much higher risk for having multiple potential exposures that can affect their growth and development and long-term potential and affect their disability. So poverty, poor stimulation, undernutrition, all impact. And so you can see that if a child, for example, had a neonatal insult and had some cerebral palsy, how that child lives, whether they're in a poor family, parents that understand how to stimulate them, their access to services, are all going to impact the potential for that child to overcome their disability or to maximize their function. And so we can't, and we just know that in LMIC settings that these other factors potentially are greater than in high income settings where children have more access to services, may have more access to programs that provide parental stimulation and those aspects of child care. So I think that potentially exacerbates the problems for children who have a disability. So thinking about that, as I said, in thinking that neonatal issues are actually one of the top things from child health, what do we know about the neurodevelopment outcomes after a child has had a neonatal or perinatal insult? So this is a systematic review that's a global review, and they looked at disabilities in the domains of cognition, motor, hearing, vision, seizure disorders, behavioral, and multi-domain. And they found that this is, again, globally, both high income and low income, that children who had a hit in the intrauterine or neonatal period had a 39% risk of having a disability in one of these domains. and 18.5% had a risk of a severe sequelae. You can see that the most common issues were learning difficulties in cognition or developmental delay, cerebral palsy, which is more of a motor problem, but can often be associated with mental and other disabilities, hearing impairment and visual impairment. But I think because we're focused, or I was thinking about this from a African perspective, it was interesting to note that they said that the review shows a paucity of studies from resource-poor countries, especially sub-Saharan Africa. And so I think it just points to the fact that a lot of the data on this is driven from other parts of the world, and it's hard to actually find good data from lower income countries, in particular in Africa. I'm going to focus now on a few studies that are there, again, looking at it from the perspective of neonatal injury, and then I'll also look a little bit around HIV, because those are two areas where there is a little bit more data. So this next slide, I think, points to an interestingly done study in Uganda, where they took 2 districts in eastern Uganda and looked at their demographic and health data in these 2 districts and said, okay, between January and March 2017, there were about 517 babies that were born in these 2 districts. And they tried to track all of those babies down. And they were able to actually track 487 of them, or 94%. And then they did a neurodevelopmental assessment of these kids between 9 and 12 months of age. And what they found was that actually 62, or 12.7%, had a neurodevelopmental disability. Now, they didn't go into a lot of details on which domains these disabilities were, but again, pointing to the fact that those early hits are a big factor, they found key associated factors were a post or neonatal complication, failure of the baby to cry at birth or known birth asphyxia. And then interestingly, which we'd have to think through what this means, is that parity of more than 3 children. So moms are being born in a family with many more kids, which may just have impact on related to caregiving, also just things that affect maternity and good care. Okay, so this next study was actually not done in Malawi. And again, they were trying to get at kind of population based problems, but they did it from a different perspective. They trained key informants. So they trained a group of people to go back to their communities and told them what to look for in the communities. And then from that, the community people identified potential candidates who they thought may have some kind of disability. And then the study then screened those personnel. And so they did this was again focused on rural districts. And they found that they estimated from this that in these districts, that 17.3 per 1,000 children had some form of disability. Again, you can see it was broad in terms of scope and types of disability. But again, physical disability came up high at 39%, 27% had hearing disability, 26% intellectual, and they included epilepsy as well and vision. And what I found interesting is when they for a couple of them, they also tried to assess what kind of care had been given. And for those that had physical disability, they found that about 2,100 per million kids would have benefited from some kind of physio OT services, but only 17% of them had ever had access to those things. Interesting, for hearing, they found that a high number, 1,800 per million, they think the hearing issues were related to conductive hearing loss, which actually could be treated relatively easily with basic ear care. So I think from these we can see that thinking about services and rehabilitation after neonatal and early injury is important. and probably would target a high percentage of kids. Now I'm gonna move a little bit to around HIV, because that sub-Saharan Africa or Southern Africa has been very much hit by the HIV epidemic. I'm going to present 2 studies from there. So this study is interesting because it was a case-controlled study looking at HIV-infected children and pairing them with their uninfected siblings. So in a sense, it's trying to control for some of those other hits that I was talking about. So theoretically, these would be kids who would have the same exposure to poverty, the same exposures to the parenting styles, and looking at then outcomes between the HIV positive child and the negative child. Again, they use this broad WHO 10 question screen, which some people are suggesting overestimates, but it's hard to know. And what they found is that 98 or 33% screened positive for a disability, and half of those had actually multiple disabilities. On the right, you can kind of see again, it was pretty broad types of disabilities that we're talking about. And what they found is that when they also looked at kind of functioning and how they were performing, they found if a child had a disability and was HIV positive, they did the worst. Then if they were actually had a disability but were HIV negative, they were the next kind of worst off. And then it was being HIV positive without a reported disability. And then obviously HIV negative without a disability was the best functioning. So there seems to be, certainly disability seems to be a big hit, but if you have HIV as well, they seem to be the ones who struggle the most. Now, again, this study was done at a center of excellence for HIV care in the capital of Malawi, where they even have EMR services in records. And I think even in the kind of, this would be the most resourced potential place of a child getting HIV care, we can see that actually 67% of the kids had never actually attended any rehab services, and just over a third had even had it noted in their medical chart that they had a disability. So it seems even when potentially they have the highest level of access and healthcare worker interaction, there's still a lag between identifying the kids who need services and getting them services. Then, so this study, again, I think points to the fact that HIV positive kids are at risk, but I'm going to also show that there may be some hope with this study. So this was a study where they looked at kids who are actually getting services, and it could be a wide variety of services, from nutritional support, health, child development support, from a community-based organization. And they had 135 HIV positive children who, I'm just putting a high percentage of these kids were on ARV treatment. And they looked at some outcomes for neurodevelopment in these kids. And they did a physical assessment. They did a couple cognitive tests, the digit span test and the draw a person test. And then also asked questions about their quality of life and school performance. And they controlled for country, because it was done in South Africa and Malawi, the caregiver gender, caregiver HIV status, household HIV, family sickness, insecurity, and whether they had to care for younger children or not in the home, which are all, again, trying to control for those other factors that can affect neurodevelopment and function. And what they found is HIV positive children were more likely to be stunted, which we know has impact on neurocognitive and long-term outcomes. Interestingly, they found that there was not an association of how the kids performed on the digit span and the draw a person tests if these factors were controlled for, but the HIV positive kids did seem to have worse physical functioning and worse school performance.
2 minutes, Professor.
Okay. So then moving on, but what we can see is that these kids actually do better over time with services. They may not catch up completely, except for maybe the physical functioning, but they do better. So why focus on this group? I think there are three main reasons that we'll quickly go through. One is that we know that early childhood is actually a time scientifically of huge neuronal collections, and how and what we do with those children in that period can actually have huge impacts on their long-term functioning. If we're signed up to the UN Convention of Child Rights, we know that children, we have the responsibility of providing them with services to reach their developmental potential. Okay. And then even if you wanted to just say from an economic resource standpoint, we know that when countries have higher functioning, less undernutrition and greater support for learning, those countries long-term have higher GDP. And it is the human capital argument, okay? So what do we know about services that work? We know that early childhood intervention is using multidisciplinary services to provide child and promote child health and well-being and minimize delays and remediate problems. And so this is often what this group of services or rehabilitation gets called, okay? And I think this is a good framework to think about it, in that we know that in a population, we have a huge number of kids that we need to just give good messaging to. They need the universal support, so policies and basic information support. And then we have kids who need targeted support. These are the kids at risk who may not necessarily have an identified disability yet, but we know that they're potentially at risk for that, and they may need more targeted supports. And then we have the kids who are identified as having a problem, who really need lots of support, and it's how to do that. The evidence for targeted support is actually growing and very good, that if we can target and give support to kids at risk, we actually can help with future learning. We know that if we target this group, they actually have long-term economic impact, not just as on their own impact or economic development, their own income in adulthood, but also on their next generations. This last study actually looked both at the income of the children who had received these early services, but also then their children, and showed that it actually improves that as well. We know that from high income countries, we need to optimize motor, cognitive, and communication, and this involves physio, occupational speech, and language therapies. We need to try and prevent secondary impairments by medical interventions, and we need to promote caregiver coping and mental health strategies, as that is often higher for a caregiver caring for these children. For targeted, for that indicated support, the kids who have really major disabilities, there are definitely small studies. They're not as widespread studies showing this works, but it's definitely building the evidence that intervening with these kids can actually also have long-term impacts. And what we know, almost done here, but is that, so what are the problems in getting these services in LMIC settings? And so this one again was done looking across Africa, and what they found is that there were 4 things that can be barriers that need to be considered as we think about rehab services in these settings. One is just attitudes, beliefs, and awareness of both healthcare workers and the families, such as stigma with children with disabilities, community, personal beliefs that can be cultural. So, I mean, it can be anything from just nothing can be done, that kind of attitude, to beliefs around that child is cursed, and so therefore we shouldn't do anything. But also that there can actually just be a lack of awareness that some of these screening and studies actually showed that the kids that scored as having a problem, the parents didn't necessarily even recognize that there was a problem there. So they need to actually first recognize there's a problem. Certainly accessibility of services is a huge barrier, not enough personnel, equipment, so that even if a parent or a healthcare worker recognizes that this child would need services, there just aren't places to refer to. And then the physical environment, such things as, parents and families in these communities say, okay, I know there's a physiotherapist or services at the hospital, but how do I get my disabled child there? I have a hard time riding the bus with them. I have a hard time, you know, when weather hits and the roads are muddy, I can't just wheel them or walk with them to it. And then obviously social factors, you know, a family who's living in poverty may say, look, I can't take off the time to walk to the hospital to get the services. That means I'm not out in the fields working or at my job, and we won't have income to support us as a family. And then privacy was an interesting one for adolescents who often said they didn't come in for care because they needed a caregiver to go with them, and they didn't feel that they were offered the privacy that was needed.
Professor, 30 seconds.
Okay. And then facilitating things for peer support and giving families coping strategies are things that really can help. These were found to be things that allowed people to get services. And so I think in conclusion, we see that some of this data is suggesting that key components of services need to involve peer-to-peer training. They need that support and coping support. We need to promote the responsive caregiving, which is a lot of the early intervention type of services. And then again, trying to prevent secondary complications such as malnutrition or other things. And based on the data of where these people are, often we need to be looking for community-based interventions like that CBO intervention, and maybe involve home visits and stuff, taking services to the children because of the other barriers as transport and so forth that are very hard. So I think just in conclusion, I think this is a huge area of need. I think it's an area that's going to be growing as we see under 5 and childhood mortality drop. I think these areas of morbidity are going to increase. But although we have evidence from high-income countries of the types of services needed, I think we have to think through how we adapt them and bring them to the communities that need them the most. So thank you.
So thank you, Tonya. So before Professor Sobrepera starts, let me launch the poll again so we can learn more about you. So we have 1 minute for you to vote to let us know what's your occupation.
Okay, and during that 1 minute, I think I should go ahead and start sharing my screen.
Yeah, please.
Okay. Just let me know when you're ready for me to get going.
Okay. So people stop answer. So I will end the poll. I will share just the results so you can see who is your audience. So we have 10% of them engineering, 14% as therapists, 14 physicians, and 10% a nurse, no technical expert, and 52% are other. If you could please add to the chat what's your occupation, we would love to hear. So please, Sobrepera, the floor is yours.
Awesome, thanks. I'm Michael. I'm going to be talking to you all today about a project we've been working on for some time to develop these social robots for remote assessment of children with disability. And I'm going to start off with a couple of videos. So this is what we're working on right now. It's a social robot on top of a mobile telepresence platform. And the whole idea is to be able to deliver therapy to patients remotely, but while still having some physical presence. You can see the clinician is mounted or is on the screen up top, and then you still have this social robot that's moving around. It can demonstrate activities, its face can change, etc. And from the, oh, that jumped a lot of slides. From the clinician's perspective, this is what they see. They have an interface where they can see all the cameras, can drive the robot around, they can control games, tell it to speak, change the faces, etc. And the reason why we're doing this is a lot of things that Dr. Mills was just talking about. So thinking about how do you lower costs of care, how do you handle geographic disparities, changing demographics, and general shortages of clinicians to meet growing demands. And for rehab, this is so important because, as we all know, rehab is so interaction dependent. If you have more interactions, you can have better outcomes, and if you don't, you're going to have poorer outcomes. And so our goal is to develop the system and also test whether this humanoid actually has any effect. And then also to build on top of these cameras that you saw to have a computer vision based system to do objective assessment of upper extremity function. So A lot of assessments aren't objective today. Over telepresence, you can do assessments, but they're really time consuming. Most clinicians we've talked to don't want to do them. And so we want to do that. And then with COVID-19, we've been looking at some testing as to whether this sort of robot makes sense in those situations. And we've also been doing some surveys. And the fundamental underneath this is that when you're in person with a patient, there are all these interactions that develop, all these modes of communication, the instruction, the emotion, the diagnostics you're able to get, and the motivation you're able to provide. And that over telepresence, a lot of those things fall away. So right now, if I tell you to clap your hands, I can be clapping my hands all day and you can't see that. So you can maybe see me like saying to touch my head or something like that. And I could back up and now you can say, maybe I could say like touch your left shoulder with your right arm. But now you can't really see my face anymore. And even with that, it's still just not in person. So the idea is, can we use this social robot to add in some of that richness back while still having the clinician there? Because I think it's really important that the clinicians stay deeply engaged with their patient care. And there's a lot of evidence to suggest that using robots for stuff like this is a good idea. People have compared tablets, like really simple systems like this, asking people questions about their health and having them do exercise, and the robot does better. Compared robots in person versus the exact same robot via a camera, and shown that people are willing to do more uncomfortable tasks, like throwing away really expensive textbooks with the in-person robot. The question comes up that perhaps it's the size of the robot that's the problem. Well, no, people have tested that as well. Bigger robots projected on screens do the same as smaller robots projected on screens. And this has even been tested with kids using social robots. And here you find some really interesting ordering effects where kids who are just interacting with the social robot interact very well. Kids who are interacting with the screen for the first time don't do anything, just kind of sit there and stare at the screen. And kids who've interacted with the robot before and then are now interacting with the screen will interact somewhat, but not nearly as much as in person. And so as a result, people started to get more interested in building these social robots to interact with kids in this sort of physical way. That's social, right? So we're looking at people who have motor disabilities, and you're able to drive them through those activities. This Now Therapist project corrects them as they go through games. It's really interesting. And so we built an early prototype quite a while ago that consisted of a Now robot, which was and still is in large ways a standard for these small social robots, on top of a commercial telepresence platform. And this was tested at that time with elder care facilities and in rehab hospitals. And we got a bunch of feedback from them on what needed to happen with the system to make it more feasible and to make it more interesting to them. And we took that and began to design the system we're working on right now, the one I've already showed you, called Little Flow. And so we worked with the designer to really sketch out what we thought a system would look like. And we wanted to build our own system from the top to the bottom because we wanted to have complete control over the design, over the programming under the hood, over the ability to modify it and test with it. And so the designers also helped us develop a series of faces for the robot. And we ended up with this head and these series of faces. And we had, kind of pen and paper come up with a series of emotions that we thought that these represented, but we wanted to see if we were on the right track. And so we tested that with a small cohort of actually just college students in this case, and showed them the various faces in a randomized order and asked them just what was the first thing that popped in their mind for each one. And we condensed that down, and that allowed us to provide ratings for each of these faces. So you can see that some of the faces are very sad, some of them are happy, and some of them are very murky. And somewhat interestingly, this one kind of in the middle here, if I have a mouse, this one right here was our original neutral face that we just used for a lot of interactions. And it turns out that that one was really creepy, as was one of our other neutral faces over here. And so it actually changed the way that we were thinking about some of our faces and adjusted what we use. And we ended up with this condensed set of faces that we think express a series of emotions clearly and that we like to use more consistently. And I would say that this robot's been shown to, at this point, hundreds of kids from outreach events, tours of the lab, that sort of thing. And it's really interesting. They react to these faces much more than I would have initially thought they would. So when you give them the sad eyes with little eyebrows on it, this one in the middle here, they audibly will go like, "Aw." And so that's pretty exciting to see that this sort of emotion can communicate. And so we created a mechanical design for the system that was meant to be as simple as possible, so that it could be as repairable as possible, as robust as possible. And that was also lightweight. So the entire system is just exoskeleton based with these off-the-shelf motors that provide digital control over all the motion. And then the head that you've already seen, it's actually 2 3D printed components, and the front is a molded in plastic that's actually dyed transparent black. And so you can't see the matrices inside, but you have these matrices shine through that give you all those emotions. And so looking at the range of motion that we get, we have this right here. These numbers might not mean much, but essentially it's good in most directions. It matches human range of motion, except from the elbow. The elbow flexion is significantly limited down to just about 90 degrees, which is not anatomical. And then really important for people who have things like CP, we're missing wrist and hand involvement. But we still think that you can drive a lot of interactions in this way much better than you would be able to through telepresence alone. So we're testing that. And so this is what that range of motion gets, right? The robot can go all sorts of different places, including dabbing over here, which was requested by kids during a outreach event. And so you can start to demonstrate these activities, go through motions, and build these fun interactions. And to test this robot, right, the fundamental idea was this telepresence robot. The social robot makes the telepresence better. We're able to remove the social robot from the system and also use it without that. So we have this really nice comparison that we can do as to how people interact with the two of them. And I mentioned that we were trying to do this objective assessment. So both for that reason and for giving the operator a clear view of where they're operating, there are 3 cameras mounted on the robot. There's this wide angle fisheye lens, as well as these 2 depth cameras. And so it was important to place these so that we could have a good view of the space and get data that would hopefully allow us to do rich analyses later on. And so that's what this ends up looking like, both when a subject is sitting far away, as well as when they're close up, maybe doing a target touch type of activity with the hands. You can see them and you get back this depth data. So you can start to do some interesting things with kinematics. I think you've already seen the interface. And so now we've taken this all up, and when COVID hit, our ability to do traditional research changed, but we saw a new opportunity for systems like this. And so we wanted to understand, in general, how has COVID affected care? How has that changed the way telepresence is used and telerehab is done? And then also how people feel about robots in general and this robot in particular. And so we're still working on going through all this data. But the first group I'll show you, we looked at the first 364 therapists in the United States who responded to this and who had more than 1 year of experience and looked at what needs they had and what kind of concerns they might have. And so this is a little rough to look at, but this was the first set of questions we asked them, what features they thought they would be important. And so the thing to highlight here is that high quality video and clear screens are by far winning this competition. And so if you can build the coolest robot out there that does whatever thing, and it doesn't have clear video and a high quality screen, you're not building the right thing. And that's important for us roboticists who really like cool things to keep in mind, to do the fundamentals well. There's also this automated assessment. It has a 74% positive result. And so that kind of validates, we think, this idea that building these automated assessments that are objective using the computer vision is something that the field will be receptive to. And then the other things kind of trickle down from there. We also asked for feelings towards robots more generally, not necessarily this particular robot. And so you see a lot of people are saying that they want these robots or robotic systems to be studied more, that they're concerned that they're too expensive. They want to maintain clinician control. So again, we're taking it back and we'll look really strongly at doing this telepresence with the robot type thing as opposed to doing fully autonomous robots. I don't actually think autonomy is ready. I think that it'll be really interesting to look into automating components of it, like the assessment, like driving the robot around, which you'll see down here, that they don't really want to be driving the robot. But yeah, and then down here at the bottom, you can see that that's reinforced by a second question where we asked if they wanted automated systems, and 70% said no. And so we condensed this down because that's a little bit tough to look at. And so you can see that there are concerns over feasibility. There were generally positive feelings towards low flows features. People were not generally negative. But at the same time, the questions that were positive, we didn't really see any significance there. So they were just pretty neutral. And then those highlighted questions for features that are critical to telepresence were very positive responses, and people were positive towards wanting to see more understanding and regulation. And then so we also looked with 351 of the therapists, first 351 who answered in the United States with more than 1 year of experience again, about their excitement and perceived utility of this particular platform. And so looking at how interested they would be from not at all interested to very interested, you can see that it skews not interested. But for a novel technology that I didn't mention earlier, I should have said the survey showed them a video of low flow, like a 3-minute introduction video. And that was their level of exposure to low flow. None of these people had any prior exposure. That having 27% of them rate that they were interested, just more than 50% interested, we think is actually pretty interesting and pretty reassuring, encouraging. And then we looked at specific components that they thought low flow would change in their interaction. So how do you believe that adding a social robot as a companion for your patients during video and audio telepresence interactions, such as low flow, would change the following when compared with traditional video and audio telepresence-based rehab? And they thought that it would improve communication and motivation and compliance. And we defined compliance as being during the interaction and adherence as being longer term. And we found that the compliance, motivation, and communication were all improved. Assessment and adherence, we didn't see a change. And this survey, so far I've said that we did this in the United States, which is exciting, but we would love to see how the responses change in various resource settings and various cultural and geographic settings. So this survey is actually still open, and we would love to see responses from elsewhere. So if you are either a clinician there, you can still fill out the survey. Having seen this presentation, there's just a question there where we ask if you've seen a presentation of it, as well as if you have people that you know, collaborators, that'd be great if they could fill this out. And so now in the future, we're looking at, in addition to that survey, doing feasibility testing, where we just kind of give the robot to clinicians and say, use it and we'll see what happens. And that'll give us a better idea of what they actually do and don't use, as well as looking at the interaction modes. So how do people respond, whether in person with a social robot or telepresence without a social robot? And I want to circle back around. I mentioned this automated motor function assessment multiple times, and that therapists seemed really excited about it. And so when we think about that, there are some tests out there that are relatively objective, like the box and block. You're moving blocks from one side to the other. There are notes that are taken, observing motion, but the fundamentals of there's a score of how many blocks make it over the box in 1 minute. And so can you make those sorts of objective measures with computer vision? And people have in the past. When the Kinect came out, there was a huge growth of that sort of thing. And so using the Kinect to, for example, measure a volume of space that the patient can reach is a little bit different than using a goniometer, and perhaps tells you something more relevant about the patient's actual level of function in the world. As well as like really classical work looking at the kinematics of motion. So how smooth or not smooth is a patient's motion. Right after a stroke, we know it's generally not going to be smooth. Their motion primitives fall out and are seen individually. That improves with time, and a normal person has totally smooth motion. And so could you measure someone's movement through space using just cameras? And we think you can, and we're hopefully going to use the data that we're collecting in these other studies to try this out. And this is what that looks like. So using machine learning to track myself in this case, this is just on a cell phone camera, bring it back into 3 dimensions, extract those kinematics. You can see they're relatively smooth, and try to build some diagnostics on top of that. And so with that, I will finish up. This has been a team project. There's a large team that's worked on it, and they've been fantastic to work with. And I encourage you, I'm funded by the NIH underneath an F31, so thank you to the NIH for that. And if you have any questions, please, or comments, thoughts, I'd love to hear them all. Just shoot me an email. Yeah, thank you.
Thank you, Michael. Thank you, Tonya, for your presentation. It was really nice. So now I'm asking Professor Tonya to join again, and Michelle Johnson as well. We have 5 questions now on the chat. So let's start with, how much is the health department to do empower the education system, because you find that these kids struggle at school? I think that's for you, Tonya.
Yeah, no, that's a great question, and I think unfortunately an area where we certainly from my experience in Botswana is not well integrated. we found it's actually very hard to get kids fully assessed and figure out what their needs are for school. And even when you can do that, and for the kids that have assessments, because I mean, in the Botswana setting, they are theoretically supposed to be able to have those assessments through the education system. And as a healthcare provider, we refer to that. But in terms of then actually getting the services, it's just having the number of people needed, to do the assessments in the first place, and the skill sets, and then being able to provide the services. So I think it's a huge area of need, and is not been well done. So I think it's, yeah. We often use social workers, we do referral letters, involve our rehab colleagues in it, but it's very difficult. And the other thing that I think is missing, and I don't know where the advocacy for this could be, is getting kids assessed early enough. So what we found, certainly in places like Botswana, is that when kids enter school and then the school starts picking up problems, they will drive an assessment. But when we as healthcare providers are interacting with these kids when they're 2, 3, and services then could then prevent school problems, it's very hard to get them properly assessed and into services, early intervention services early. So I hope that answers. It's unfortunately, it's I would say an answer that doesn't have a lot of hope right now, but I think is an area of great need.
So next question. Hello, Professor Tonya. Thanks for the presentation. I did not find any point on the intervention of AT to improve the functioning of the children with disabilities.
I was just wondering, what do they mean by AT? I just wasn't sure. Huh?
Assistive technology, right?
Oh, okay. Oh, yes. No, I agree. And there is some data out there that basically access to rehab services in general is very low, and patients getting that access. But then in terms of assisted technology, it's even lower. And so I didn't focus on that because I was doing much more of a broad swath in the 20 minutes that I had. But it's, yeah, it's also a huge area of need. But I think to be able to get assisted technology, you need to get kids into services. They need to have the assessments. There needs to be the recognition that there are things that can be done. To then the next step is then getting them the tech that can support them. So that I would say, you know, given the gap we're seeing even in just accessing rehab services, this is even bigger gap.
Michael, this one for you. Michael, this is great. Wondering about the faces and identification of emotions. Did you have a chance to test in different cultural settings yet? Malcolm Gladwell talks about studies that show that facial expressions may not translate across cultures as easily as we have been taught to believe.
Yeah, I think that's definitely accurate. I don't think that the emotions or faces would translate well. We haven't done that testing, but part of what was interesting about our system is that it uses these LED matrices for the eyes and the mouth. And so as long as whatever changed emotion could be displayed in that format, then we can adjust those faces based on the cultural context, right? So that would testing had to be redone, the faces recalibrated, and then you could go from there. And it's something that would be interesting to do. We'd love to do that in the future.
And how did the use of social robots compare with conventional therapy?
My guess is that it's, for this type of thing, not going to be as good as having a therapist hands-on, 3 days a week or something like that. That being said, if you look at a lot of patients who aren't able to receive that amount of care because of their challenges from cost, challenges from where they live, et cetera, then if you could supplement care with a therapist, then we think we can improve the quality. So it's not meant to compete with traditional therapy at all. It's meant to be a supplement on top of it.
And how have you looked further for the intervention of the social robot in LMICs, consider the sustainability and affordability factors?
Yeah, so I will say this system is not yet ready to be deployed in many LMICs. It's just still too expensive, but it's an order of magnitude cheaper than our prior system we developed, I think 6 years ago. And so in 6 years, if you can drop an order of magnitude price, the next order of magnitude price drop would make it affordable for LMICs. And so we want to try to prove out some of these systems, understand what are the critical components that could be developed and then deployed there. And maybe there are parts of it that get taken out and could be in an LMIC today, right? So if we could get the automated assessment from video working well, that is affordable to deploy in an LMIC, even if the social robot isn't. And so you start to look at, how could you augment telepresence in other ways? I think that there's a lot of opportunity. This system isn't there yet, but we'll get there.
Can I add something to what Michael just said? One philosophy of our lab is that so the social robot that's being developed in the lab, the little Flo, one of our philosophies is that when we work with LMICs, a part of the burden of cost is in the labor. And one of the things that we've seen in the past is it can become even that much more affordable if some of the parts of the labor is actually done within the LMIC. So if we, for example, wanted to work with someone in sub-Saharan Africa on this little Flow project, what we would probably want to do is a lot of the labor and the work that was done here in the US, we would need to translate that and have some of that being done inside the country. And we find that when we do that, it reduces the cost substantially. So even though the current version of Little Flow is not ready for prime time in LMIC, there could be a way to make it a lot more affordable by actually doing a lot of the labor and a lot of the manufacturing in country.
Okay, let me see, we have no more questions. So we have still 3 minutes. So Professor Tonya, do we want to say a final words?
I think my final words are, I think just that, I know this talk is focusing on children and activities for rehab and children, but I think that just in general, don't forget the kids. I think that often when things are developed, they're the afterthought of, oh, how can it be done? But I think that there are probably some unique opportunities for long-term impact if rehab in this population is targeted. And thinking about how we take it to the communities and out is going to be key, whether we're doing robotics or not. So that would be my.
Dr. Sobrepera?
Yeah, not doctor, but I think really thinking about ways in which technology can be used to augment the clinicians is really important, and framing it in that way, and therefore allowing the clinicians to be partners in what's being developed as opposed to being adversarial is really critical. But these systems can be very cool. They can extend the reach of clinicians, make them see more patients further and more broadly. I think that's really exciting.
Not doctor yet. And Professor Michelle Johnson, do you want to say a few words about the next webinar?
Yes, I just wanted to thank Dr. Arscott-Mills for her talk, as well as Michael Sobrepera. Michael is the 5th-year student in my lab and was an excellent talk. Both of these talks kind of highlight this idea of there is a need to really seriously think about intervention or creative ways of doing intervention with children or adults and thinking through the whole telemedicine aspect of it. So our next talk is going to kind of focus on the area of a cognitive assessment and rehab. And the flyer is up now. You'll be able to register for it as of later on today. And we'll be featuring 2 clinicians from Botswana, the University of Botswana, and they'll be kind of talking about their work in this area of neuropsychology assessment and making those more automated and more available in Botswana and other low and middle income countries like Botswana. Thank you guys again.
I have shared the registers and the register link in our chat. So if you want to register for this next webinar, please use this link.
Thank you everyone for attending.
Thank you.
Thank you all.
Bye-bye, guys.
So Nini, if you have a minute, once everyone leaves the call, can you stop recording, or are you still recording?
I have stopped recording.